welcome Chairperson of the session, Dr. S.M. Manohari and Dr. Christina George onto the stage. I would also like to welcome speakers of the session, Dr. Snehal Gupta, Dr. Priya Sridharan, and Dr. Luke Salazar. Dr. S.M. Manohari has been the ex-HOD Department of Psychiatry, SJMC, Bangalore. She has worked as a registrar in psychiatry in the United Kingdom. She attained her membership to the Royal College of Psychiatrists and completed DNB in psychiatry and returned to India. As a teacher, she taught psychiatry to undergraduate medical students, budding nurses, and postgraduates in psychiatry and other specialty residents. She also ensured a change in UG syllabus, making psychiatry interesting and appropriate for an MBBS doctor, much ahead of the current curriculum-based medical education. In her role as the head of the PG committee, she ensured that the movie clips, book reviews, and debates were regular teaching learning methods in the academic schedule and used ASCIIs on regular basis for formative assessment. Her areas of interest include child and adolescent mental health, eating disorders, psychiatric rehabilitation, and in psychiatry teaching. I would also like to welcome Dr. Christina George. She is a professor in Dr. SMCSI Medical College and Hospital. She's been an undergraduate teacher for 23 years and as a postgraduate teacher since 13 years. She's a convener for IPS UG Education Subcommittee. Her areas of interest include consultation license psychiatry, medical education, old age psychiatry, and perinatal psychiatry. I request the moderator of the session to please introduce our speakers. Thank you.
Very good afternoon, everyone. I'd like to introduce Dr. Snehal Gupta first. He's an associate professor at AIIMS Bhopal. He's a peer reviewer in several journals, including Lancet Regional Health, BMJ, which are really prestigious journals. He has been awarded the Best Research Paper Award in 2021-22 at the All India Institute of Medical Sciences, Bhopal. He's received the Dr. G.C. Borel Award, National Conference of IASP in 2018, International Travel Support from ICMR and CSIR in 2018, Scholarship for Training Enrichment of Psychiatry Teaching Students by ITOP. He also is the General Secretary and General Secretary of the Indian chapter of World Association of Dynamic Psychiatry. Has editorial roles in the form of being an associate editor of Future Health Aims and assistant editor in IJPM and IJSP. He has current research grants from the ICMR. His areas of interest include psychiatry education and training, common mental health disorders, preventive psychiatry, psychosis also. The second speaker is Dr. Priya Sridharan, who is also my student. She is currently the professor of psychiatry at St. John's Medical College and Hospital. She is a corresponding author of papers shortlisted for Bombay Psychiatric Society Award 2018 Ranchi. The paper was titled Challenges in Taking Sexual History, Qualitative Study of Indian Postgraduate Psychiatry Train. The other award was for the Indian Postgraduate Psychiatry Training and in the Indian Journal of Psychological Medicine. She's been corresponding author for paper which won the S.S. Jairam Award for Best Paper at Indian Psychiatric Society, South Zone at Wayanad, Kerala. Paper was titled Challenges in Taking Sexual History. She was shortlisted for the Bhagwat Award 2016 in the annual National Conference of Indian Psychiatric Society for the Best Original Paper for people who are less than 25 years. Her areas of interest include common mental health disorders, psychiatry teaching and medical education, suicide prevention and intervention, and general hospital psychiatry. Welcome to Dr. Priya. The third speaker is Dr. Luke Salazar. He is also my student. He is currently an associate professor at St. John's Medical College Hospital. He has contributed towards the Indian Teachers of Psychiatry award for undergraduate training, psychiatry training. He has papers pertaining to undergraduate teaching in the Indian Journal of Psychological Medicine. He also has published about competency-based medical education in undergraduates in the another paper in the Indian Journal of Psychological Medicine. Since the curriculum, the competency-based medical education started, he's been very actively involved, and as you can see, many of the publications of his publications are from that area. His area of interest is consultation liaison psychiatry, and when the fellowship program was ongoing in St. John's, he was the coordinator for the consultation liaison fellowship program. He also is interested in psychiatry education and common mental disorders. Fine. So with that introduction of the speakers, we'd like to start the session. I think all teachers, whether they are seniors or juniors, are always worried about completing assessments. Most of the seniors would agree that when we assess a student for the long case presentation during the exams, we get a complete picture of the knowledge of the person, as well as the empathy, abilities, and the interviewing skills and management skills, but still a lot of objectivity is missed in that. Each person assesses in a different way. So, and probably assessing knowledge can be easier than assessing all the other more important abilities that a student needs to have as a psychiatrist. Mainly we are looking at objectivity. Also, even when we are seeing the student over a period of time, so that we have an ongoing assessment of the student with all the summative and formative aspects put in. During the exam, supposing the student has an off day, is the student allowed to have an off day and not do well in that particular section of the exam, or is there an inbuilt mechanism that ensures that those kinds of difficulties are avoided when we assess students? So let's listen to our speakers about how we can blend the traditional ways of assessment, so that currently when we are looking at having to assess 150, 200 undergraduate students, or probably 15 postgraduate students in a day, how we go about doing it in a more effective manner.
If I may just come in, I believe all of you will have around 12 minutes, but you're going to split it, so we need to watch time as we're running behind. The other thing is, can the undergraduates put their hands up? Yes, they've been large in number, but very quiet otherwise. Remember, assessment drives learning. I think all of you can perk your ears up, and we would like to hear from you what you feel about assessment in CBME and anything to do with psychiatry, okay? So we'll welcome your questions. Okay, start off. Yeah.
Yeah. Thank you, ma'am, for the introductions, and thank you to the organizers for giving us this opportunity to talk about assessments in CBME. the overview for today's symposium, I will briefly introduce the topic. Dr. Snehil will be talking about UG assessments, and Dr. Priya will talk about PG assessments, and then I will come in later to talk briefly about how to put it all together in a more practical sense. As with everything CBME, we'd like to start with the objectives. So at the end of the session, what we'd like you to be able to do is list traditional and innovative, formative and summative assessments. Deploy these assessment methods in your PG and UG teaching programs. Understand the implementation pearls and pitfalls of a CBME assessment program. Why the fuss about assessment in CBME? Because assessment is king. What we mean by this is, in a CBME framework, formative assessments, like ma'am was just saying, drive learning, and summative assessments are used in high stakes situations to make judgments about readiness to progress. So this is why we need to discuss today about assessments in CBME. We'd like to keep our presentations short, and we'd like to reserve some time for the audience to come in, because there are a lot of experienced teachers who we want to stimulate some discussion. I'll now hand over to Dr. Snehil to present on UG assessments.
Thank you, Dr. Luke, and good afternoon, everyone. I would consider it as a privilege to make presentation in front of my teacher and my co-teachers and mentors who have taught me significantly in this area. So I'll be covering the UG part, so the presentation would follow this flow. How did I approach this presentation? Overview of assessment in psychiatry for undergraduates as outlined by NMC and IPS task force, various assessment methods, its strengths and limitations, my personal account for assessment. Need to be put in slide. Okay, thank you. And the summary. As such, I do not have any conflict of interest concerning these presentations. However, there are a few disclosures. As ma'am highlighted, I have received ITOP STEP scholarship. I am a member of Center for Medical Education of Training, AIIMS Bhopal, UG and intern course coordinator in psychiatry. And I have received a grant from the research cell AIIMS Bhopal for conducting an early exposure psychiatry and enrichment program for second year MBBS students. So in my institute, first psychiatry exposure happens in 6th semester, that too theory. And in 7th semester, they have the clinical exposure, so it's relatively late. So concerning the presentation, I try to reflect on what I should be talking about when the audience involves effective teachers who have done great work in the field, review the available literature, obtaining the perspective of psychiatry teachers whom I know and whom I follow, and then there were mutual discussions among three of us. So these were the common traditional as well as innovative assessment methods that emerged following the discussion. Reflective writing was pointed out by quite a few teachers, then mini clinical examination, role play as in clinical scenario can drive learning, clinical scenario as given in CBME document as well as IPS task force, and other traditionally used assessment methods. So concerning the overview of assessment in psychiatry, so there are two agencies we may call who have contributed significantly to this area, and we have been following. Like you see the NMC document, in doctor-patient relationship they have given some competencies, and usually the assessment is directly observation of performance and then small group discussion. The assessment method includes viva voce, skill stations, faculty observations. Likewise, the draft of IPS, they have also outlined various novel assessment methods as well, which includes involving, apart from traditional methods like OSCEs, OSLERs, directly observed performance, and case-based discussion. So let's come on to what are the strengths and weaknesses of various assessment methods. So first of all, reflective writing is considered a very good approach, particularly to teach AdCom to the students. And there are a number of papers which have established its efficacy among the medical students. So narrative writing, narrative medicine and reflective writings is useful in terms that student recapture their experience, think about it, evaluate their learning needs and learn accordingly. And it expand beyond just traditional healing approach rather than going into the more complexity of healing in patient care. It not only strengthens physician or student-patient relationship, but the relationship of doctor with oneself, with his colleagues or with society at large, and helps a student or say a clinician in terms of better medical and humanistic effectiveness. And putting your learning into practice and emphasizing it is important. That we call it reflection during action. So until unless students are aware that how reflection can drive their professional growth, it would be difficult for them to take up this particular teaching learning method as well as assessment. What could be the limitations for reflective writing, for assessment or even for learning? It can be burdensome for the students, it can be time consuming. Faculties are not adequately trained in how to conduct reflective writing. It can seem patronizing to the student when we say we want to teach you AdCom through this method. They may say we have that trait, that's why we have taken medicine, because we are empathetic and so on and so forth, and some people can feel too touchy about the whole process. So considering my reflection, so we have used this approach with the second year MBBS students, and through reflective writing they have been given a situation. Like for instance, there was a session, this was a non-routine session. It is not for the routine classes but for the participants of early exposure psychiatry enrichment program who voluntarily took this program to enhance their mental health and psychiatry skills. So they were given this task, assignment on ethics in psychiatry, communication through reflective writings. So there were set SLOs which was conducted across over 2 sessions. In first session they were oriented about the reflective writing, and then what would be the flow, what is expected out of them, and how the feedback session would be conducted. So this was a case scenario given to them. Ideally even a live exposure to patient can be a better method, but it may not be practical in all the situations. So a real-time case scenario was given for to them, including a person with intellectual disability and psychosis and significant caregiver burden, and the faculty's consultants' dilemma in handling them. So they were given a task to write a narrative account highlighting on these 5 points: how they describe the situation, what is their feeling about the case, how they evaluate the current situation, what is the analysis, and how do they plan their course of action. So students have written about it, about their experience, and which usually covers the area like I can understand the severity of the illness of the patient, I can understand the limitation of treatment, the dilemma of a consultant, the caregiving burden both for the family members and for the consultant, and what the government resources should be and how it can be improved. Second is the OSLER, which is objective structured long examination record. So this is a typical assessment method. So it is an improvised version of long examination that we usually do, which is considered less valid and reliable methods because there are many biases involved with it, and it is not a comprehensive assessment. So while in OSLER it follows a long examination pattern, but the examiners observe the candidate while he takes interview. So it's in long case we allow them to take interview and then come and present their finding. Here the assessor observes while they conduct interview, and then they are graded based on whether they performed very good, average or below average on 10 different items, which may include history taking, physical examination and management plans. So it has found to be greater acceptability among the teachers as well as students, because it is just a variant of long case examination. So it doesn't require much changes in terms of resources or in terms of changing one's style of taking exam. So this is a good method in that sense, which can be utilized for assessment, and has also been highlighted by IPS task force. Difficulty level can also be taken into account while assessing. Another commonly used method is OSCE, and people have used it for undergraduates in psychiatry during their initial years also. And they have OSCE, as we all know, it is a time-bound, station-based assessment which is observed and is a structured method. It is done by a trained assessor. It is a replacement of short case and at time Viva also, designed to match interview and communication skills of the undergraduate, their clinical competency, and usually covers the show how skill of Miller's pyramid. Well-designed OSCE can drive learning and therefore have a positive educational impact. IPS has given the framework how it can be conducted across the professional years, which we can follow. However, there are some limitations when it comes to OSCE, because teachers training is required. It is a time-consuming process, and though we are doing a part of the overall assessment, it may miss the overall construct of a case. So concerning how we did OSCE in our award living test for 7th semester MBBS students, so the assessment would take place under case-based assessment, which is a cognitive domain part, and then the OSCE would basically focus on the skill assessment. So student will be given a few preset conditions, and an SR would act as an actor, and student would try to demonstrate the skill that is required on their part, and then they are rated based on a preset format like communication skill, knowledge about the subject, presenting their findings, and immediately they are given feedback also. So it is more of a formative kind of work. Then the case-based assessment, which is we commonly use, it basically assesses for cognitive domain. So our personal account is, if we have a focused case-based assessment with sub-questions which are also very focused, then it is useful. Otherwise, students can mug up the answers, can have superficial reading and still can get mark. So proper case description is important, and specific responses that is warranted from them. The limitations can be, you have to again refresh your questions practice question bank. It can be challenging to create new questioning, but it can also allow for scope of malpractice, because students tend to discuss their responses with each other. Viva is other. I'll take 2 more minutes. I'm spending time, just 1 more minute. So Viva was, as we all know, it is used in assessing both the breadth as well as depth of responses from the students. However, it involves high subjectivity. The another benefit of Viva is, apart from knowledge part, it can also capture the affective domain. So how to overcome the bias or limitations? By having a preset questionnaires, having model answers, and multiple assessors on board. And there are research which has shown that structured Viva votes can promote learning, can provide a uniform, equitable and unbiased assessment. So this is a summary slide. I think for us as a psychiatry teachers, we need to understand that assessment for medical student in psychiatry is paramount to ensure quality medical education. If it is objective, structured, covering diverse topics, use different methods, and involving multiple assessors, the assessment can be robust. However, it warrants a teamwork and lots of preparation on part of teachers. We can involve senior residents, and their training is also important. And we need to learn, innovate, and share our mutual experiences like we are doing here. to make the whole assessment system more robust. And I think formative assessment should always be coupled with some kind of feedback to the student. Thank you very much for the patient listening.
Thank you. I hope I'm audible. So Dr. Snehal has covered quite a bit of what I was saying in terms of assessments. So I will focus on assessments in post-graduation. As I think it's a statement that's going to be repeated a lot over the next 2 days, but assessments really drive learning. And the whole point of learning is to get change. So taking that into account, the specific learning objectives of my part of the presentation will be, we are looking at formative, summative assessments in postgraduate curriculum and postgraduate psychiatry training, and we are looking at the real world use and what are the innovations we can make despite the mandate on us. So the crucial thing about formative assessments are extremely important in PG psychiatry training. We are all doing it. We need to be aware of it. We need to be cognizant of it. The way formative assessments differ from summative assessments, we all know that, but it's worthwhile reiterating it again and again, is they involve a series of tools and approaches to measure learning throughout the journey of education. Formative assessments help us identify the strengths, weaknesses, opportunities, and threats. And by identification, as Dr. Snehal reiterated right now, we give them the necessary feedback on this, and they learn from this feedback. By learning from this feedback, they make the necessary change. This is helpful in, one, bringing about effective learning. Secondly, this is also helpful in self-directed learning. If you tell a postgraduate student, this is a rubbish case presentation, nothing really happens. What is the student going to learn? On the other hand, if you tell the postgraduate student, look, we did the OSLR, in this OSLR, you have missed out these points in terms of past history, in your mental status examination, this has been missed. This is clear criteria for the student, and the student can work on it. If this is a student who keeps forgetting past history and the student has been given that specific feedback, the student will work on it. That's where formative assessments help, because through the formative assessments, through the feedback, we get change and learning. So if we look at teaching learning methods and assessments are interlinked in CBME. We cannot separate them anymore. So Dr. Snehal has already covered some of them, but I'll just briefly touch upon crucial differentiating points. I'm just covering 5 of them. All right, we're looking at the directly observed procedural skill TOPS, which is used a lot in MRCP, mini clinical examination, which I suspect all of us are doing periodically during training, but we are not realizing that. Case-based discussions, simulations, and again multi-source feedback. So briefly, it comes under the realm of workplace assessments. It is conducted by the supervisor. Basically, the supervisor assesses the candidate as they're doing the procedure. This is commonly used in MRCP. This is commonly used in Australia. This is being used in Indian settings, probably not being published. That's why we're not aware of it. DOPS basically looks at procedure. How is the individual doing the procedure? Now, there is a little bit of query on what are the procedures that you're looking at in psychiatry. Are you looking at primarily ECT administration, RTMS, ketamine administration? Are we going into the affective domain as CBME describes it? They call it the cognitive psychomotor affective domain. Are we going into the affective domain where we are looking at suicide risk assessment, or how do you restrain a particular patient? Can that be considered a procedure, or do we involve mental status examination itself as a procedure? That is a question mark, and that gets complicated because we have other assessments, that is the mini clinical examination. The mini clinical examination, again, like TOPS, is the direct observation of the candidate by the supervisor, and this is during a clinical encounter. So if you look at both DOPS and you look at mini clinical examination, this is occurring during the procedure. As of now, most of the papers which have looked at this have not looked at simulations. They have looked at direct observation or direct examination during the procedure. The timing is typically 15 to 20 minutes of observation, and as mentioned, and as I will be reiterating again and again, and many people will be reiterating, the observation has to be followed by feedback. There is no point in doing an observation and a checklist without a feedback. Now, how do we do it? For example, your student is presenting the case, or your student is evaluating a patient here. You are primarily doing a mini clinical examination for the evaluation of how the student evaluates affect, or how the student evaluates formal thought disorder. So as I mentioned, the previous slide was about DOPS. So there is this question mark of, do we keep DOPS for strictly procedures in psychiatry, and do we keep mini clinical examinations just for phenomenology assessments and history taking? I think it's fluid. I think we can really work on it, but more importantly, most of us psychiatry teachers are doing it. We do it when our PGs are evaluating our patients in our OPDs, in front of us. We just need to be aware that this is actually an assessment method that we're doing, and a formative assessment method from which we can give them a feedback, okay? Case-based discussions. In the Northern America journals, it's also known as chart simulated recall. Okay, what happens here is the trainees have worked up their cases. They take the cases that they have worked up, and they sit with their supervisor, and the discussion with the supervisor is on these records. For example, your first workup is of someone who's had psychosis, you've taken the onset, duration, progress, past history, your MSc, and then you put in a management plan. So then the discussion could be on what basis did you call this a delusion, or on what basis is this the diagnosis, differential diagnosis, why wasn't this diagnosis given a priority? So after this discussion, there will be feedback. If you have to operationalize it, the discussion could be probably for 15-20 minutes, the feedback could be for 5-10 minutes, the feedback could be on the basis of a predetermined checklist that the examiner has, but these are what we call as case-based discussions. Case-based discussions, mini clinical examinations, and in all settings which have ECTs and other procedures are all, that is DOPS, are all amenable to be implemented in our current scenario. We just have to juggle around the operations around it. When we finally come into simulations. Simulations are basically, we are imitating a process in real world, and we are bringing it about, and we are assessing it. So for example, your role play, which is the most commonly used simulation, where you look at suicide risk assessment as part of role plays, because supervisors are naturally anxious that they don't want a real life suicidal patient to be evaluated and part of it. That point of time, you can, similar to how you do in OSCE and all of that, you can either borrow the OSCE model, or you can either borrow the Osler model. You have a simulated actor, have a predetermined checklist, and you can evaluate the candidate. Of course, you give the feedback. So you can actually blend an existing formative assessment method with simulations. This is the most important thing, multi-source feedback. This is extremely important. I think AIMS Raipur had a beautiful paper in the recent academic psychiatry supplement that was published by IJPM, and they have described this in detail, and this is something I think all PG settings are actually doing, but they're not aware that they're doing it. We are looking at assessment of competence from multiple sources. These multiple sources obviously could be the senior resident, the thesis guide, the professor, whomsoever is evaluating, but you can get feedback from peers, you can get feedback from juniors, nursing staff, patients. Actually, there's involvement of patient in this case. It's not a technique, more it should be considered as an approach. Just to go quickly, where summative assessments, as I say, differ from formative assessments, are high stakes. They are the end of the journey, not during the journey. They considered as a final measure of learning, not just as a process bringing about learning, and often they determine licensing. Examination, yes, we all know about it, but thesis, please remember, is actually can be considered a summative assessment, beautifully brought about by paper by our senior residents and a young faculty from St. John's. If you look at examination process, Dr. Snehal has already spoken about the long case where we can use Osler, the short case where we can use OSCE, Viva, but pedagogy especially, because we're all teachers here. Rajiv Gandhi University of Health Sciences uses pedagogy as one of the assessments in their final summative MD exam, where they evaluate the candidate for around 40 marks. They give them a topic, they give them 5 minutes, and they evaluate the candidate to see if if the candidate had to explain depression to undergraduates, how the candidate would do that. So I think this is something that can be considered in summative examination, and I think Dr. Survi had asked about whether you can bring in competencies to see how students can teach. Maybe that can be considered in the summative examination also. Dr. Ajay's paper is a beautiful paper that has described how I think their team has gone about doing formative assessments in real world. We are doing all of this. What we need to do is document it, and what we need to do is give feedback to the students, and we need to have clear objective criteria. That's what it is. Some innovations, Dr. Manohari actually brought in our department a lot of exposure to movie clubs. Suhas and the new UG/PG team have brought in mock courts and all of that. But how do you assess it? These are teaching learning methods, but how do you assess it? In this case, the assessment can more focus on intercommunication skills, group activity, resourcefulness, the number of time, the drive, the way they communicated. That is one way of doing assessments when you bring in innovative teaching learning methods. And finally, I think the Rajiv Gandhi, during the COVID, when we couldn't get patients and the MD students had to be examined, used case-based discussions as a summative measure, which was an existing formative assessment measure being used as a final summative assessment, where we all took the case records of students patients that they worked, and we evaluated them, and it turned out to be a very good experience. The candidates were actually quite relaxed. To summarize, we are assessing, we need to operationalize it, and crucially, we need to give feedback. That is what we need to take into account. Thank you. I will go to Dr. Luke.
Thanks, Dr. Priya. I'll give them the express version. Yeah, so in the interest of time, I think I'll go a little faster. Yeah, we're done with this. Okay, so putting it all together, we've kind of described assessment methods for UG and PG. What I want to talk about briefly is some of the practical stuff that may be useful in actually deploying these methods. So to answer some of the questions that ma'am raised as well, multiple methods, these could be structured, unstructured, qualitative or quantitative. The rationale being to be able to compensate for the shortcomings of any one method. Factors that could influence the use of multiple methods could be what information are you trying to assess, what competencies are you trying to assess, the levels of performance expected, the learner's stage within Miller's pyramid, and certain systemic factors like the number of faculty at your disposal for doing the assessments. Programmatic assessment is to be able to implement a particular structured program for how you do these assessments, and I'll show you in the next slide what I mean. Blueprinting is you want to be able to tap into all the most important competencies that you absolutely require them to have, the student. We must not shy away from assessing what is important, not just what is easy. So for example, certifiable skills are something that you absolutely want to assess. Higher the stakes, more assessment. So like the question that Dr. Manohari raised in the beginning, suppose a student has an off day and it's a high stakes examination, like a summative assessment. You want to be able to have multiple methods so that the one bad performance does not bias the overall assessment. So for example, I put down here something that we do in our UG clinical postings, where we have a diagnostic assessment for depression, and we have this reflected in an MCQ. We have an OSCE and a portfolio that they use through the posting. This is the competencies mapped onto Miller's pyramid, and this is the direction that you want to take. So from the nose to the knows how, shows, and then does. By does, what we mean is basically work-based assessments that both the speakers were talking about. This is something that I want to introduce you to, Goodhart's law. It's basically when a measure becomes a target, it ceases to be a good measure. What I mean by this is we have to be able to weight our assessments properly based on what exactly are the skills that we want to assess. So it can be an unintended consequence while planning assessment programs. I can give you two examples. To my mind, the next one, it's difficult to imagine that the final year UG students will be reading much of clinical stuff in their final year, because they know at the end of the year they've got to answer a test which is entirely MCQ. Okay, something that may be relevant to us is using, say for example, the metric of number of publications for promotion could be another. This can be mitigated by using structured approaches in the design of assessment programs, that is more weightage to the shows how and does assessments, and using qualitative approaches. Using multiple assessors is another strategy. The rationale is to overcome biases, halo effects, meaning one assessment biasing the overall assessment, leniency. The factors that may go into this are time that may be allowed to observe the learner or the person taking the exam, expertise of the rater, and again systemic factors, the number of faculty, the space to be able to do this. Dr. Snehil alluded to this in his talk, where we try generally to make assessments objective by using scoring checklists, say for example in an OSCE, but the research actually suggests that expert global judgments approach the validity, or sometimes can be superior to the validity of these objective methods, and this emphasizes the need for qualitative methods of assessment. An example could be, again, something that was talked about earlier, multiple assessors who use an oscillor in a PG exam, say for example. Assessor training is something also that was spoken about earlier. The focus should be, what are the goals of the assessment? The focus of training, that is. Competency is being assessed, observational and recording tasks, assessment instruments, documentation, how to give feedback. This is something I'll talk about again later. The rationale being to be able to calibrate raters and improve inter-rater reliability. Assessor training has to be feasible and meaningful and integrated into an ongoing faculty development. This is something that is Dr. Kishore has spoken a lot about, and I think there will be sessions again tomorrow on this. The use of technology can make our tasks of assessment sometimes easier. So for example, you could use an LMS, a dashboard, where you give visual feedback to the assessor and people running the program, the students. You have a logbook. And of course, now with the advent of AI, this is can be a useful tool in assessment. It helps to design and facilitate assessments, improve documentation, which is something that's very important in CBME, like Dr. Priya was speaking about. It allows to provide feedback on performance. So you could have an MCQ, if it's on an LMS, you can give them immediate feedback about why this was the wrong answer and what is the correct answer. It can help map progress and address gaps in individual and program level issues. It also informs progression decisions and other important judgments about learners in high stakes assessment. Factors that could influence the use of IT, of course, is to be able to have a good IT support. This may sometimes be a barrier. This is I put down as an example. You could actually use images in psychiatry in assessments. You don't usually think about this, but this image was generated by Meta AI by certain prompts that I gave it. So you can feed in, generate an image of a woman with depression and cite a paper where there are certain name signs of depression, like the omega sign and very good sign. That I think it didn't give me exactly what I wanted, but it's close. Giving feedback is another essential skill, like Dr. Priya was talking about. Formative feedback shared with trainees can help them correct behavior that is ineffective or unsafe and reinforces behaviors that are effective. Faculty must be skilled in conveying this feedback and in creating a positive and safe environment. Learners need to be willing to accept critical feedback. I'll take 2 minutes. And 1 minute, okay. Feedback loops must also exist between faculty, learners and program directors to ensure that there is innovation and quality improvement of the program. Feedback forms can be structured, objective or qualitative. Yeah, thank you.
Thank you very much. It was a wonderful exposition of a lot of material that I'm sure informed the audience. Before I get to the UGs, let me just maybe ask a few questions that have come in. One you have answered, how do you train assessors periodically? You have told us what is to be trained, but how to train inter-rater reliability, calibration of, examine the examiners. So anyone willing to take that up? How would it be feasible within
If I may.
Indian medical? Okay.
I can share my experience with the UG assessments that we do in our department, and the senior residents are integral to the running of the assessment program. The people who design, that is the faculty from the UG committee who are involved in designing of the assessment schedule, we sit down with the assessors and we walk them through, like I was saying in my presentation, what exactly we are trying to assess, how to actually score. Say for example on an OSCE, there are no half marks. There you need to score either a 0 or a 1. Simple things like that. So stuff about the assessment goals, stuff about the instruments that we're using, those kind of aspects, and we need to kind of run the programs again and again when there's turnover. That's another important
Sure.
part.
I think it's happening at department level. I think the larger question would be how to standardize such assessments and whether there should be some certification of assessors as such. But that's just a comment. Now, one more question that has come up, and maybe the undergraduates can come in on this. Logbooks are assessment tools. I know they're your worst enemies. Logbooks are assessment tools we already have. This has come from Dr. Harish Kulkarni. Sorry, the other question was from Dr. Sean. Logbooks are assessment tools we already have, but they've become last-minute formality. How can we improve their usefulness?
This question is difficult to answer because in many departments in psychiatry, UG don't follow logbooks.
We have logbooks, and I've taken a survey giving 10 things, and the thing they've scored the least favorite is the logbook.
Even for faculty also.
Yeah.
In my institute, it is also
because we
there
have
for
logbooks,
faculty.
very elaborate logbooks for AdCom and less elaborate for psychiatry. So I've done an ACME project on that. So any of the undergraduates would like to come out on that? Do any of you, never mind psychiatry, do any of you keep logbooks for any of the subjects? Anyone wants to come up with that and your opinion about it? Remember, we're not your undergraduate teachers, so anyone? Are they good? You like them? How can they be improved? No one.
If I can just add, yeah, go ahead.
Go ahead.
If I can just add, see, logbooks, if they are given a task and the department makes it compulsory that it has to be entered within 2 days of whatever work they have done. They cannot come at the end of the posting and then you also forget who has done what. And probably the difficulty for the student is doing it on time. For the faculty to give a feedback to an undergraduate student, you don't want to be discouraging them. So that is an important thing to remember. But logbooks can be really useful to move ahead.
Okay, another question, this is anonymous. How can we strike the right balance between preserving time-tested teaching methods, I assume assessment methods in psychiatry, and integrating cutting-edge new innovations? So, for example, I noticed that some of your presentations were more on the new innovative techniques and less on, our structured essays and, short answer questions. I mean, not as a, so how do we balance the two is the question. How do we strike the right balance?
I don't think the traditional methods are going away. I think they're very much going to be there.
Yes.
I think the innovation is in how do we assess them objectively. using the traditional methods. That's what the Osler strives for. That's what the OSCE, okay, you can argue there is a sense of artificiality in it, but if you're looking at the Osler or you're looking at the multi-source feedback, it's traditional. We are just documenting it, we're just operationalizing it, we're bringing clarity to it, and we're bringing the element of feedback. Innovative methods have to come because assessment goes hand in hand with teaching learning methods. The more teaching learning methods will get innovated because we are living in an age of social media. ChatGPT is coming in, everything is coming in. We can't wish it away. So you are going to have newer forms of teaching learning method depending on how students are learning, and the assessments will follow the teaching learning methods. Okay. The assessments will be traditional then.
We're a little short of time. Yes.
Can I add to this? Any novel teaching learning method can only be successful if the students as well as the faculties are oriented about it. What are the benefits?
Okay.
If we don't do that, so it will be a headache for everyone.
Okay. In the interest of time, this is the last question. How do you as senior, or shall we say competent teachers, address bias in your assessments despite assessments being, or at least trying to be, objective? So this is Dr. Sean. How do we address bias? Do we examine ourselves? Do we look into ourselves? How do you address this?
Like the blueprinting kind of thing. As a teacher or assessor, you need to be ready with what answer you expect of a particular item. If you are not sure about it, your biases would come into picture. Another thing would be, though it may not be practical, but having more than one assessor, just as an observer, how you are assessing, why you are rating a particular score to a person based on his or her responses. So those kind of cognitive interview is also required.
Sure. Thank you. Ma'am, you'd like to announce the best question? Okay, I will go ahead. So it was
Lots of questions.
Yeah, there are a lot of questions. For example, there's one about, no, we don't have time. Can the candidate choose what kind of assessment methods, would suit them? Yeah, so we're not answering that. And how do you remove anxiety of students? Isn't that skill a teacher or assessment should, how do you train yourself on that? And questions like that. And how many times should we reassess a student who has not passed? Okay, now we know NMC says remedial, re-examine, remedial, re-examine, make them competent, okay? And learning LMS use, that was the other thing. So the best question goes to bias. Dr. Sean, how do you as senior teachers, ma'am, you hand over. How
we'll
do
just finish the concluding remarks?
Yeah. How do you as senior teachers address bias in your assessments despite the assessment being objective? Dr. Sean. Okay, ma'am, you can make the concluding comments.
Just to conclude, before we give the prize to Dr. Sean, I'd like to conclude by saying that assessments are not easy. You need a lot of faculty time for it, and no faculty is free. With all the demands of the clinical work and the research things that you need to do, this is something that is delegated and delegated again. So we need to ensure that seniors participate in these assessment methods. They will be role models for the senior residents and the younger teachers to follow. Assessing students is a skill that has to be taught during the teaching programs that we have for senior residents and young faculty. Also, one important thing, what amazed me was the driving test that I took in UK. They were very clear. You need to know A, B, C. They're not bothered if you know D, E, F or 100 other things. All they want to know is, are you a safe driver? So the goals are so clear. I know we can't do that in medicine, but if we have some clarity about what exactly our goal is, then our assessment becomes much more easier, though it is always going to be time consuming. So thank you. All the presentations were excellent, and thank you to all presenters.
Thank you so much.
Now,
Thank
Dr.
you.
Sean. No bias.
I request Dr. Pratap Sharan to present souvenirs to the moderator of the session. I request our moderators to present souvenirs to the speakers of the session.
Thank you very much.
I think 1 hour. Priya?
Okay, I think we'll not waste the time. We'll start off the session. I'm Dr. Kiran, Professor and HOD at Department of Psychiatry, Vaidya Institute of Medical Sciences and Research Center. And I will hand over the mic to Dr. Shahul Haman, who will be my co-chair.
Good morning, everyone. Two quick comments about the topic of using technology in psychiatric teaching. Actually, first one is a bit critical because when I was doing my first year MD in 2001 in CIP Ranchi, the very first case conference and seminar I did using that OHP, overhead projector, and writing on the sheets and all. PowerPoint was around by the time, but to get that become mainstream, it took another 1 or 2 years. So I have seen the evolution. So even in the past, say more than about 20-25 years, we haven't even learned to use PowerPoint in the effective manner. Forget the aesthetic part. For example, when there is a bulleted list, almost all slides of most speakers are bulleted lists. So when we have 5 lists, at least Dr. Luke did it very appropriately. When the first item is there, only that should be visible. When you are moving to a new slide, if all your 5 bullets are visible, what happens? You are explaining the first one, but the audience is busy reading the entire slide. So they are not paying attention to you. And we are the specialty that deals with like attention, concentration and all. But we don't pay attention to that in our, even the major conferences. And after that, around 15 years ago, the smart art came, where you can have beautiful lists and hierarchies and processes and flowcharts and all. Very rarely people use that. So what I'm going to say is, like, even if they are going to speak about a lot of new technologies, like in research, in clinical practice, we talk about the translational gap between research and clinical practice. Like that, even if technologies come, unless we implement them properly, it is not going to benefit our students, our audience. That is one thing. The second thing is my own wish list for what I want to see in technology in learning. The first one would be an AI-powered robot that we can use to, say, teach psychotherapy. Say the robot is here, I am telling it, now you are a 35-year-old man with alcoholism, I am going to do MET with you. And I do MET, and the robot gives the appropriate answers, and in the end, the robot gives me the feedback where I went wrong. That is one thing. The second would be a VR goggle that can take us into the brain to show the various what actually goes wrong, where there is aberrant pruning, where there is an excess of dopamine, where there is a dearth of serotonin, what happens when you give the medicines and all. That kind of tools, if they come, that will make it very interesting, even for UGs, PGs, everyone to understand psychiatry and respect psychiatry. With these comments, I